This is a 70-year-old gentleman with biopsy-proven angiosarcoma of the scalp. We will excise it with 3 centimeter margins and up to the bone in local anesthesia. When we are giving local anesthesia, if we can get above the periosteum, we can easily inject the whole scalp. And when we inject beneath the tumor, if we can see it rising, we are sure that it's not attached to the underlying bone. Always give the inferior incision first because blood flows from a superior to inferior direction. If you give the superior incision first, then blood will flow inferiorly and disturb your marking. Dissect through all layers of the scalp and get to the periosteum at least on 1/3 of the lesion. Cut periosteum with blade and elevate it with the periosteal elevator all the way to the other margin of excision. While elevating, also make sure that the tumor is not attached to the underlying bone. Once periosteum is elevated, then the tumor can be excised from all the other margins. Always place marking suture before removing the tumor fully. Then remove the tumor. It's always a good idea to burn the bone just below the tumor area. Before reconstruction, change your gloves and the instruments. Flap should be 5 times the size of the defect and should be based on the blood supply of the scalp. Always inject the supraorbital and supratrochlear area in the forehead because nerve territories of these nerves are not blocked by giving anesthesia in the scalp. Now you already have a plane from where you excise the tumor and you can elevate your flap above the periosteum surrounding that area, and this will help you in raising the flap later. Once this plane has been developed, skin incision can be given and flap raised. Flap is now easily raised above the periosteum. We have a plane here where the flap has been raised from the periosteum, from the tumor side, and from the incision margin we are raising the flap. If the defect is not closing properly, undermine the surrounding edges. This is also done just above the periosteum. Flap is now rotated into the defect. Due to undermining, most of the donor side will be closed primarily. At closure, the little area left is going to be left for secondary intention and will heal without any issues. This is at 3 days and at 3 weeks.